Alright, so in the last video we covered a lot of things related to the basal ganglia and dopamine and movement, and there was a lot of very technical stuff, and then we did a couple practice questions. We also covered the cerebellum. We were done with that. Now we're looking at the outer part of the brain, right? So we started deep inside. We started with the thalamus, the hypothalamus, the basal ganglia, and all of that. Now we're looking at the actual cerebral cortex. Generally speaking, it has many regions, many more than what you see here, but there's only so much you need to know for your actual step one. One of the things we've actually been looking at in terms of the brain in the way you see it here, there's a couple of sulci and fissures you really need to know pretty well. The most important of which is your central sulcus, this one right here. So the central sulcus, this line actually delineates the primary motor and the primary somatosensory cortices, right? So you can see the difference. So the motor cortex is the one in the front, the somatosensory one is right behind it. And these two guys are the ones that are receiving a lot of the input we've been seeing so far, right? So like from VPL, VPM, all of those guys that were from the thalamus and hypothalamus, those nuclei, they send information to these two areas depending on whether it's motor or sensory. Other than that, there are three association areas you need to know really well. There's your prefrontal cortex over here, the limbic association area, and then there's another posterior association area where the parietal, temporal, and occipital lobes kind of associate information together. So you can get questions based off of injury to the brain, right? Whether it be because of some kind of hemorrhage from inside or some kind of accident from the outside, like a trauma. Different parts of the brain can get injured, and then based off of that, you're going to see different presentation in the patient. So the anterior association area, also called the prefrontal cortex, is the cerebral cortex covering the front part of the frontal lobe. This brain region has been implicated in planning complex cognitive behavior, personality expression, decision making, and moderating social behavior. So I'm sure you've all seen a question at some point where prefrontal cortex injury led to the patient acting in a very sexual manner, very inappropriate manner, speaking like a joker, acting like a complete douchebag, right? All of those things because they've lost that inhibition. They've lost that ability to know what is correct, right? So very, very bad cognitive behavior and personality changes occur when you have damage to the prefrontal cortex, which is your anterior association area. The limbic association area, it's not just this. If you find other pictures of your limbic association area, there's also a part of it that's on the medial frontal lobe. So medial frontal lobe and anterior ventral temporal lobe. So the limbic association area is what helps form memories and translates that to motor responses, as well as processes emotions and guides emotional responses. So the memory and motor responses part is going to be very important for sports, right? Being able to throw the basketball the correct way, swing your hand at a tennis ball the right way, stuff like that. And then emotions and emotional responses are going to be based off of, if someone just gave birth, then you have certain emotional responses to that. Someone just died, you have different emotional responses for that. Those things. Those are all going to come from the limbic association area. And remember, anytime you think of limbic, do not think of limbs like hands and legs, but think of limbo, which is like, being caught between reality and what is not real. So if you have damage to the limbic association area, you no longer act the way you would actually act in reality. So someone comes and tells you, hey, my father just passed away, or something along those lines, you're supposed to be sympathetic and stuff like that. But these people might just have a blank stare and not really care if you have injury to your limbic association area. The last area is your posterior association area. This is located at the junction of the occipital, parietal, and temporal lobe. So this area right here where all three kind of cross over, it links information from the primary and unimodal sensory areas, and it's important in perception and language. All right, so what you see, not just perception in terms of what's happening, but also body language, perceiving body language. That's a major function of the posterior association area. Other than that, there's the somatosensory association area up here. That's literally just for associating sensory things to what might be causing the sensation you're feeling. We're also going to have an entire page focused on the Broca and Wernicke areas and the connection between them, which is the arcuate fasciculus. For understanding language, we have Wernicke, and speaking correctly, we have Broca. All right. So that's all of that. These are all the different parts of here. And the latter half of this page brings up a really big topic, very high yield, cerebral perfusion. So cerebral perfusion, we talked a little bit about in cardiovascular, where we said CO2 was the main player for managing or maintaining correct cerebral perfusion. It relies on tight autoregulation, which is a topic. Autoregulation is a topic in cardiovascular, primarily driven by PCO2. Oxygen also modulates perfusion, but only in severe hypoxia. Also relies on a pressure gradient between the mean arterial pressure and the intracranial pressure. Low blood pressure or high intracranial pressure decreases cerebral perfusion pressure. All right. So therapeutic hyperventilation is something that a lot of people do. Right? So if you breathe really, really quickly, now it's therapeutic when you need it, but if you do it when you don't need it, then it's not therapeutic. Then it just makes you feel really weird. So if you hyperventilate out of nowhere, you lose all your CO2. Losing all your CO2 leads to vasoconstriction and decreases your cerebral blood flow. That in turn will lower your intracranial pressure, right? Lesser blood flow, lesser pressure. And this is something you can use to treat acute cerebral edema that can be secondary to a stroke and unresponsive to other interventions, right? So if you have cerebral edema, you just go ahead and hyperventilate and things start feeling better. So they give you this equation now. Cerebral perfusion pressure is equal to mean arterial pressure minus intracranial pressure, right? And if your cerebral perfusion pressure is equal to 0, that means you're not perfusing your brain and you're going to die, right? Where can that happen? Well, if your intracranial pressure gets really big, then MAP minus ICP can become 0, right? Because you're subtracting your intracranial pressure. So ideally, if you throw numbers on it, then sure, maybe your mean arterial pressure is something like 10, and intracranial pressure is like 1. If your intracranial pressure becomes 10, then 10 minus 10 is going to be 0, and that's going to be a problem. So you don't want to have a very high intracranial pressure. That sucks, okay? You also don't want to have a very low mean arterial pressure. If your mean arterial pressure comes down to like 2 in the same example, then there isn't much space left, right? Intracranial pressure can easily just become 2. It's not that big of a difference, and that'll also equal 0, so you'll die. Hypoxemia increases cerebral perfusion pressure only if PO2 is less than 50. Right, so less than 50. So now this graph we're going to look at and break down. So on the x-axis here you have pressure. On the y-axis is cerebral blood flow. How much blood is actually going into your brain. So oxygen is only going to be significant at numbers below 50. So you can see here PaO2, your red line. This is only significant below 50. After that, it stays stable. It doesn't change anymore. Okay. Cerebral perfusion pressure is directly proportional to PCO2 until PCO2 is more than 90. So you can see how as PCO2 is increasing, right, as you go from left to right, your PCO2 value is approaching 90, and at the same time it's also going upwards, right? It's a graph and there are points associated, so always remember to look at all the points. There's nothing more than just reading, right? You're just reading the graph. So as you go from left to right, you're also going upwards. So basically, as the pressure is increasing, the CO2 pressure is increasing, your cerebral blood flow is also increasing, right? That's also going upwards towards 100. Right? So as PCO2 reaches 100, cerebral blood flow also reaches 100. After 100, then it doesn't have an effect. PaCO2 is stable. Right? They say 90 here. So this graph and this question are relevant things to this stuff that comes from UWorld, right? But before I go there, you can see your two lines, right? You can see the PO2 one right here. This is your oxygen pressure. This is your CO2 pressure. The same lines just separated over here into two graphs, right? UWorld and Step 1 in general also loves combining multiple graphs onto the same graph. So that's what's kind of happening here. They threw another graph here. This is your mean arterial pressure, right? Mean arterial pressure. You can see that as you go from left to right, mean arterial pressure was increasing up to here and then stayed stable between 60 to 150. Then it started increasing again. So increasing mean arterial pressure also has an effect on your cerebral blood flow, but only at the extremes. Either when your mean arterial pressure is very low or very, very high. Both of those are two different scenarios where you can really increase cerebral blood flow. So now how do you get tested on this? So here you have a question. 32-year-old female with claustrophobia is stuck in a malfunctioning elevator. So claustrophobia is a fear of being stuck in small places. and being stuck in a malfunctioning elevator is scary for even those who don't have claustrophobia. She experiences severe anxiety as well as dizziness, weakness, and blurred vision. What is the most likely cause of her symptoms? Right? So why is she acting like she's hypotensive and about to faint? The answer is decreased arterial partial CO2 tension, right? Decreased CO2. So you can also work this graph from right to left. She is most likely having a panic attack, which is usually accompanied by hyperventilation and hypocapnia, losing CO2. Hypocapnia causes decreased cerebral perfusion and thus neurological symptoms. Remember we said that as you increase the pressure of CO2, you increase cerebral blood flow. Well, it works the other way too. If you go from right to left, if you decrease your pressure of CO2, you also decrease your cerebral blood flow. Right? You go from all the way up here to down here as you go from right to left. Okay? So hypocapnia causes decreased cerebral perfusion and thus neurological symptoms. The image below was given with the explanation. An increase in CO2 from 25 to 100 causes a linear increase in cerebral blood flow, as you can see from here, 25 to about 100. As you're going from left to right, you're also going down to up. Right? But then you notice after 100, as you go from left to right, it's not going up anymore. So cerebral blood flow is not going up anymore, even though you're increasing CO2 pressure. Since hypocapnia can decrease cerebral blood flow, patients with cerebral edema hyperventilate to decrease intracranial pressure. The PO2, oxygen pressure, has a much less influence on cerebral blood flow. For the oxygen pressure in the range of 50 to 100, cerebral perfusion remains constant. As you can see, from 50 to all the way to whatever, as you go from left to right, cerebral perfusion is not affected. Severe hypoxia, where you go from 50 to near zero as your oxygen pressure goes really, really low, leads to a rapid increase in cerebral blood flow and intracranial pressure. Other vasoactive substances in the systemic circulation do not affect cerebral blood flow since they cannot cross the blood-brain barrier. Right, so 4 questions you want to remember that if oxygen is less than 50 or CO2 is decreasing from 100 downwards, then you're going to have effects on cerebral perfusion. If oxygen is going to be very low, you bring more blood to the brain. You see how you go from 50 to 0 for oxygen. As you go from 50 to 0, you're going upwards. You're increasing cerebral blood flow. For CO2, when you go from 100 to 0, as you lose CO2, you also lose cerebral perfusion. So oxygen and CO2 have different effects. As you can see, the 2 graphs are opposites of each other. Right? This one is increasing, this one is decreasing. But you want to think of it from right to left, right? Because you're always going to be losing oxygen, not gaining oxygen. And you're going to be losing CO2 in majority of questions. So if you're losing CO2, right, then you go from 100 to 0 for CO2, you also go downwards, right? You go downwards, you decrease your perfusion of blood flow to the brain. And for oxygen, as you go from 50 to 0, because you're losing oxygen for whatever reason, that hypoxia or hypoxemia causes an increase in cerebral blood flow. You bring more blood to the brain so you can bring more oxygen to the brain. That's the concept there. Okay. There's another question here. This one's from Amboss. This is related to a different topic, but it says a 54-year-old man with hypertension and congenital blindness comes to the physician because he is unable to recognize objects by touch with his right hand. The symptoms started about 2 hours ago. When given a house key, he can feel the object in his right hand, but is not able to identify what it is. This patient's condition is most likely caused by a lesion in which of the following locations? And this is in the contralateral superior parietal lobule. Remember right here you have your somatosensory association cortex, and I was telling you earlier that if you have your sensing, right, the primary somatosensory cortex, whatever you're sensing, you should be able to associate it with something. Right, so when you feel something, you should be able to associate it with what it is. This guy's somatosensory cortex is probably not working. Right, this somatosensory association area, not the cortex, the somatosensory association area is probably injured or has some kind of hemorrhage or something. The ability to recognize objects by touch is called stereognosis. Tactile information is processed by the secondary somatosensory cortex, known as the somatosensory association cortex. This somatosensory association cortex is located in the superior parietal lobule and is involved in tactile information processing and spatial orientation. A lesion in this area can cause astereognosis, where you can't tell what you're touching anymore, as seen in this patient. And you also get hemispatial neglect. You neglect half the world, which is typical for right hemisphere lesions. And we're going to see that later on when we get to pathology. Okay, so remember we talked about the anterior, limbic, and posterior association areas, which were not really labeled here. And then this is the somatosensory association area, where you're supposed to be able to associate what you're touching with something you know of. So if you're holding keys, you should know they're keys. Right? There's a reason you know it's keys when you're just holding it, even if you're blind, because you have a somatosensory association area. Okay, and this cerebral perfusion stuff, just make sure you remember the numbers, right? CO2 is from 0 to 100, oxygen is from 0 to 50. If you're losing oxygen, if your oxygen is very low, you send more blood to the brain to bring oxygen. If you're losing CO2, you also stop sending blood to the brain. So both of those are two different scenarios that you have to keep in mind, and then different questions are going to make you utilize that information in different ways. The next page breaks down the motor and sensory parts that we just looked at. So basically we're cutting the brain right here at the central sulcus, and we're going to be looking at the primary motor cortex and the primary somatosensory cortex on two different sides. Okay, so this is the motor cortex, which is in front of the arcuate, not the arcuate, the central sulcus. Alright, so the motor homunculus is in front of the central sulcus, and the sensory homunculus is behind the central sulcus. And we're looking at both parts, and what you're supposed to know is that each one of these areas have different blood supply and work for different parts of your body. So you can see the blood supply is color-coded. You have your anterior, middle, and posterior cerebral arteries. The anterior cerebral artery is for the medial section. The middle cerebral artery takes care of the biggest part, and the posterior cerebral artery usually mainly takes care of more of the internal parts of the brain. So it only has effect on the very latter, ending portions here that aren't even related to the homunculus. But it's color-coded, so you know where it is. And then you get questions that are very straightforward for this, right? So let's read this first. So topographic representation. Topography is like making a map. So topographic representation of motor and sensory areas in the cerebral cortex. Distorted appearance is due to the certain body regions being more richly innervated and thus having more cortical representation, right? So it's distorted like this guy right here, because our tongue, our lips, and the palms of our hands and the tip of our fingers have extremely high amounts of sensation. So they're disproportionate as opposed to this part of your hand, right? This part of your hand doesn't have crazy amounts of innervation. Your elbows have good amounts of innervation, but not so much of your wrist and the middle portion of your wrist. So parts that are innervated a lot more have bigger parts. That's why you're seeing this guy like this. Okay. So now if we look at it, you can get questions where they either tell you a damage to an artery or they can tell you what part of the brain was injured. And based off of that, you have to be able to tell what the patient will be able to do. So if the anterior cerebral artery is injured, you're mainly going to affect the legs, as you could tell, right? So this light green jade area is all legs, right? From the trunk to the hip, knee, ankle, and toes for motor, and same thing for sensory. Trunk, hip, leg, foot, toes, and the genitals. Very important to remember that. So genital sensation will be gone if you have an anterior cerebral artery infarction. The middle cerebral artery takes care of everything above the waist. Everything above the waist. So you have your shoulder, elbows, your hands, all your fingers, your neck, your face, right? So brow, eyelid, lips, your tongue, and swallowing, because this is motor. So and swallowing. The sensory part, all the same parts again, right? So your neck, head, shoulder, arm, all your fingers, your eyes, your nose, your upper lip, lower lip, very significant. You can see how big the lips are, because the bigger the size, the bigger the amount of innervation you have. That's what this homunculus is showing you, right? And then your teeth, gums, tongue, and the intra-abdominal pharynx are all responsible with the middle cerebral artery. Right? So if you have injury to any of this area, or they tell you the artery, then that's what you think of. You're going to lose sensation or lose motor capability to your hands and face. Right? And that's it. That's all you really need to know. So a question will present looking much more complicated, but be ready for that. In addition, it's always contralateral. Remember that things in your brain are going to decussate and go to the opposite part of your body. So if you lose your right anterior cerebral artery, then you're going to have symptoms on the left body parts. Okay, and that's generally it for that. I also put here, okay, so this tells us that the anterior cerebral artery is for the legs and the middle cerebral artery is for the hands and face. The posterior cerebral artery is deeper and is usually related to visual disturbances as well as some sensory disturbances due to the dorsal columns. Excuse me. B is right next to S. Okay, yeah, dorsal columns. Whoa. Okay. MCA lesions in the temporal area cause superior quadrantinopia, right? And we're going to see visual field lesions later on. So middle cerebral artery lesions in the temporal area cause superior quadrantinopia, while lesions in the parietal area cause lower quadrantinopia. So temporal versus parietal, where you can see that the middle cerebral artery covers a big portion of your brain. So whether it was lesioned in the temporal area or lesioned in the parietal area will cause two different types of visual disturbances. PCA lesions, posterior cerebral artery lesions, may cause contralateral hemianopia with macular sparing. Alright, so we're going to see that when we get there with visual disturbances, but it's always good to talk about it. You should know these things already, so if you didn't know it, then that means you're still learning it, and this is a good beginning portion, but once you see it and once you study it, you should be able to talk about it without really needing the book in front of you. So now here you can see a better job with the same three arteries and where they distribute into. So you can see that if you're looking at the anterior brain, right, the anterior cerebral artery takes care of all of that. And when they cut off the cross section, right, it's two different brains, right, two different halves. So this one is showing you the left half, this is showing you the right half. You can see that the anterior cerebral artery takes care of this entire medial section, inside, in between the two gloves. Right, so the medial area is all anterior cerebral artery. The outer parts of the gloves, as you can see from here, right, the outer parts are all middle cerebral artery. Right, the medial internal areas are all structures supplied by the anterior cerebral artery. The posterior cerebral artery takes care of everything in the back. Right, and then the other half of the medial stuff in the middle. So really important to remember those blood supplies because you're going to get a lot of questions regarding these three guys. They're really big deals. And earlier in the video before this, we talked about a random question where they were saying, something happened to a brain of a person and had an injury to it, and they're like, is the injury vascular? Vascular was one of the answer choices. Vascular is never the answer choice unless damage was done to the watershed zones, and these are your watershed zones, all right? So between anterior and middle cerebral arteries, and then the posterior and middle cerebral arteries are your cortical border zones, which are the blue areas in this image right here, or may also occur between the superficial and deep vascular territories of the middle cerebral artery, which are the red areas. All right, so these are your various watershed zones. Remember that, generally speaking, you would think that if an area is supplied by two different arteries, that it's going to have good blood supply, but the truth of the matter is, it's actually getting a little bit of blood supply from both. So that's why it's a watershed. It's not that it's getting dense amounts of blood from both supplies, but it's getting a little bit of blood supply from both. So it's basically the end of the branches of the anterior and the end of the branches of the middle cerebral artery are reaching this one area and barely supplying blood there. So if you lose blood and one of these guys stops supplying it, that area infarcts immediately. All right, so it's not actually dual blood supply, but more so leftover blood supply. These watershed areas get leftover blood. That's what they get. So infarct is usually due to severe hypotension, which causes proximal upper and lower extremity weakness, man in the barrel syndrome, higher order visual dysfunction if the posterior cerebral and middle cerebral cortical border zone is also going to stroke. Right, so that area right there. Man in the barrel syndrome is basically full paralysis. That's basically all that is. Right? You lose sensory innervation as well. They had this question right here talking about other stuff related to the watershed zones that is not mentioned on this page. So the question says, a 45-year-old smoker with a history of hypertension and diabetes comes to the emergency department with severe substernal chest pain, and ECG and cardiac catheterization are consistent with ST elevations. So he has an MI. While in the unit, he develops cardiogenic shock requiring vasopressors. The patient eventually dies from VFib, ventricular fibrillation, after a week of hospitalization. On autopsy, bilateral wedge-shaped strips of necrosis are seen over the cerebral convexity, parallel to and a few centimeters lateral to the longitudinal cerebral fissure. So basically the watershed zones, right? That's where they're seeing necrosis. The findings described are most likely caused by what? And the answer was hypoxic ischemic encephalopathy. You lost blood supply, right? Many picked the answer choice cardiac embolism, except a cardiac embolism would not cause bilateral wedge-shaped strips of necrosis. A cardiac embolism would go to one area, right, and cause necrosis there. Right? If you see it bilaterally, then that's not an embolus, that's actually lack of blood supply. But his cardiogenic shock and evidence of watershed necrosis on autopsy make hypoxic ischemic a better possibility. Profound hypotension limits blood supply to the brain, causing global cerebral ischemia. The pyramidal cells of the hippocampus and Purkinje cells of the cerebellum are the most vulnerable to ischemic injury and are usually affected first. Okay, so these two cells being affected first is also critical. Right, we've already talked about Purkinje cells already, right? We did a question in the last video where we discussed Purkinje cells and how you can have a lung cancer and make antibodies that end up attacking Purkinje cells. And I told you guys that that one page is definitely worth printing out. So print that out. It discusses a bunch of neoplastic associations you have to remember. Now we also see pyramidal cells, right? So pyramidal cells of the hippocampus and the Purkinje cells of the cerebellum are the first two cells or cell types that will die due to lack of blood supply, right? Watershed zone necrosis. The next page then goes on to deeper information about the blood supply. So now we're looking at the Circle of Willis from neuroanatomy, right? Neuroanatomy, basically. So Circle of Willis, we've been talking about ACA, MCA, and PCA, right? We just discussed these three big guys and where they supply blood. And you can kind of see it a lot better here. So you can see that your subclavian is the one that's giving this vertebral artery, which is coming up, right? Your aorta gives this branch here, the carotid, which makes an external carotid and an internal carotid. The internal carotid is the one that's coming up right here. Right, so you have your internal carotid. That's what's giving you your middle cerebral artery. Right, so you see the internal carotid artery right here. All right, so middle cerebral artery is going to come off of that. That's your internal carotid giving the middle cerebral artery, giving the anterior cerebral artery, all of that. Right, so really important to keep that in mind. Everything is internal carotid, not external, and that makes sense because it's all going deep into your brain. External is more outside, more so for the face and stuff. What else do you need to know from here? So this place right here, this is your, you can see the nerve, right? This is your optic chiasm. This is where you would have a pituitary adenoma compressing things. That's really important to remember. So you can mess up the anterior communicating artery. You can also mess up the anterior cerebral artery. Your lenticulostriate arteries are the ones that usually get lacunar infarcts. So that's going to be part of the middle cerebral. Right? What else do you need to know here? And I guess that's really it. We're going to see the cerebellar arteries in more depth later on. Right? You have these. This basically this portion right here is sitting right here with the cerebellum. Right, so you can see the inferior view. It's sitting with the cerebellum. So this area, all of this blood supply that eventually leads to your PCA, all of these guys are surrounding and supplying the cerebellum. And you will have questions on AICA injury, PICA injury. Right? You have to remember how to identify these patients. Right? Don't pick a horse that can't eat. ICA has its own things, and you need to remember those phrases to be able to identify patients, and we're going to see that soon enough. The latter half of this page talks about the venous drain, right? So durovenous sinuses, all the venous drainage, large venous channels that run through the periosteal and meningeal layers of the dura mater, drain blood from the cerebral veins and receive CSF from arachnoid granulations, empty into the internal jugular vein, right? So you can see over here it goes through the jugular foramen and then goes to the internal jugular vein after it's done draining all the blood. So it's kind of like a helmet, right? And it has a very deep central area as well. That's your cavernous sinus that we already saw earlier, a couple of videos ago. So the cavernous sinus is all where all the nerves are kind of there, right? V1, V2, a bunch of other stuff. Actually, I don't know if no, not V1, V2. Sorry, the visual ones. Cranial nerve 4, cranial nerve 3. So a lot of nerves are in that cavernous sinus area. You need to make sure you know those. Let's actually go back and look at it because I can't remember for some reason. So, Neurology. Okay, cavernous. Oh, was it before this? Okay, let's see where. Or it gets discussed much later. Much later, I think. We're gonna see it much later. You're right. Let's actually see where the later part is. This part right here, yeah. So we're gonna see the cavernous sinus in much more detail later. You can see all the nerves that are inside. So this area, this blue area in the middle, this entire thing is your cavernous sinus. You have your internal carotid artery, and then you have a bunch of nerves. So 3, 4, V1, and V2. I was right. Yeah, V1, V2, and your 6. All the visual stuff. So 3, 4, and 6, and then V1 and V2. They're all in here in the cavernous sinus. So that's going to get discussed. That's your little thing right there. But in general, all this blood gets drained eventually to your superior sagittal sinus, which then brings it to the confluence and drains it all into the sigmoid sinus. And it's easy to remember the sigmoid sinus because it's kind of like your colon. You have your sigmoid colon at the very end. So you have your sigmoid sinus until you finally just get it all into the jugular, internal jugular vein and just drain it all out. Something that can occur is venous sinus thrombosis. All right, presents with signs and symptoms of increased intracranial pressure, may lead to venous hemorrhage, and is associated with hypercoagulable states like pregnancy, oral contraceptive use, factor V laden, any of these other hypercoagulable states. And the symptoms that you'll actually see with the venous sinus thrombosis will usually depend on where the thrombosis occurred, because this is a really big sinus, right? So where did the thrombosis occur, and that's how you're going to kind of have to determine what the problem was. Cavernous sinus thrombosis is a whole different deal and can present completely differently, as we're going to see later on, because it really depends on what nerves got injured in that thrombosis. This is a question from NBME, I believe NBME 20. So a 22-year-old woman who recently emigrated from rural Mexico is brought to the emergency department 20 minutes after a generalized tonic-clonic seizure. She has a 6-week history of headaches, nausea, vomiting, and decreased visual acuity. Fundoscopic exam shows bilateral papilledema. An MRI of the brain shows enlargement of the right ventricle and findings consistent with cysticercosis. Which of the following is the most likely mechanism of the hydrocephalus in this patient? Okay, so if you're seeing enlargement of the right ventricle, right, then this is related to your ventricular system, which is coming up next. But if you're seeing enlargement of just the right ventricle, just the right ventricle, then that means that your obstruction is going to be right here. Obstruction of the right interventricular foramen, also known as the foramen of Monro. Like, this was a giveaway question, but a lot of people got it wrong. So let's actually take a look at this ventricular system, and then we'll come back to the question again. So your ventricular system is the empty parts that we didn't yet discuss. We discussed everything around it, everything inside it, but we didn't discuss this part that shows up pretty empty in MRIs. This entire thing is where you have CSF drainage happening. All right. So you have your lateral ventricles, left and right lateral ventricles. Okay, they drain back to the posterior horn. They also drain into this thing in the middle, which is your cerebral aqueduct area. So that's your third ventricle. Right, from the third ventricle, it goes into the cerebral aqueduct. You see, so you're working downwards here, right? Lateral ventricle, enter the foramen of Monro, then go to the third ventricle, then enter the cerebral aqueduct, which is green here. Enter the fourth ventricle, and from there, there's two different foramina. There are your lateral Luschka and a medial Magendie. Those guys are then ultimately going to send it to your subarachnoid space where it gets reabsorbed. Right, so this right here on the right. This is the way you basically determine flow of CSF. You have to remember that. Lateral ventricles, foramen of Monro, third ventricle, cerebral aqueduct, fourth ventricle, Luschka and Magendie, then it goes to subarachnoid space. So in this question up here, when they said that the right ventricle is enlarged, that means this guy became big. So if this guy is becoming big, the left one usually will also. And the issue must be with the interventricular foramina of Monro, right? There's two of them. There's one for the right and one for the left. And for this guy, since it's only his right, the right one is compressed. And you can see there's two in this image too when you zoom in. So you can see there's one going this way and one going that way. Okay. So this cool thing in the middle, which is your third ventricle, it has two horns going like this for each one of the two different lateral ventricles to drain from them. And for our patient in that question above, we have expansion of the right lateral ventricle because the right foramina Monroe is not working. Right? There must be stenosis at that point. There's another question up here. This one says a 9-year-old is brought to the emergency department by her parents due to severe headache, lethargy, and vomiting. Her symptoms began a few weeks ago with mild intermittent headaches and fatigue and have progressively worsened. So that information is telling you, nothing significant so far. Then they tell you that a CT scan of the brain reveals a mass lesion, enlarged lateral and third ventricles, and a normal-sized fourth ventricle. Which of the following is the most likely site of the obstruction in this patient? So you can work backwards. If your fourth ventricle is fine and everything before that is messed up, it must be at the cerebral aqueduct. Right, so something's stuck in this green area right here, causing all the CSF to be stuck in these guys and making them big, where your fourth ventricle was normal size. Right, so that's how all questions regarding the ventricular system are generally going to be. They're going to tell you what's enlarged, and then based off of what's enlarged, you have to figure out where the mass is, where the stenosis is, where the flow is not working correctly. Alright, and here it was only in the right lateral ventricles, so the stenosis was in your foramina Monroe. There's one for each side. And then in this URL question down here, it was right there at the cerebral aqueduct because everything above it was enlarged, all three of these guys, and so on. Right, so that's generally all you're going to have. CSF made by choroid plexuses located in the lateral and fourth ventricles. Okay, so you're making CSF in these guys and in the fourth ventricle. Travels to the subarachnoid space via foramina of Luschka and Magendie, is reabsorbed by the arachnoid granulations, and then drains into the dural venous sinuses, which we saw up here. Right, so after that, all your CSF comes into the venous sinus, which goes back to the internal jugular vein, and then so on and so on. Alright, so that's it for that. In the next video, we'll go into figuring out how to memorize your brainstem and where the nerves exit, because you get a lot of questions on that shit too.